Thank you all for coming. We can see that it's a really interesting topic for tonight when we're going to hear from a great panel on vertigo, dizziness, and balance. As we have so many people tonight, which is great, but we have run out of the handouts. So if any of you maybe have two per couple and you have an extra one, maybe you'd mind holding up, if you have an extra one, holding it up so that we can share them with the other people who don't have one. And if then there aren't enough, you can sign up at the back of the room to receive one later. Thank you. I'd like to remind you about a few things. Cell phones. Please take a moment to check your phone and silence the ringer. This program is recorded live, and so if the phone rings, it does interfere with it. And hearing aids are also available for anyone who may request a pair at the back of the room. The restrooms are located in the lobby area to the far right as you exit the doors at the back of this conference room. Also, there will be a video replay of tonight's program next Monday, October the 21st, at 10 a.m. in the West Tower, second floor, room C, which, if you go out, it's a building straight ahead or behind you as you're sitting here now. And reservations are not required for that. You can also purchase DVDs, and the cost is $15. And there is an order sheet located in the back. Lectures are available for up to a year afterwards on demand. And if you want to watch them, you visit www.torranceMemorial.org/MOL. And sometimes it takes maybe a week or two to get tonight's program organized, but it is streamed live. After the speakers give their presentation, we will take a short break, and then the committee will collect your questions for the question and answer session. Please write your questions during the break. Paper and pencils are available, and please see one of the Miracle of Living committee members or go to the back table. Our speakers will reply to your questions from the stage panel, and we do ask that you write the questions, because if you try to speak from the audience, it doesn't come over in the video, so we appreciate your cooperation. And at the close of the program, we ask that you please fill out the evaluation form and return it at the back table. We really do rely on your feedback, and next Tuesday morning we will be reviewing the evaluations. And I'd like to remind you that next month the program will be a week earlier due to the observation of Thanksgiving. So the next program in November will be on November the 13th, which will be the second Wednesday. There will also, before that program, there will be a wellness fair, which will start at 5:30. So we invite you to come and check out. There will be a demonstration of our latest Da Vinci 11 surgical robot. And now on to tonight's program. The moderator for tonight is Frank Miles, who is a committee member. Please help me welcome Frank. Thank you.
Thank you and good evening. Are we recording now? Okay, since we just started recording, let me repeat one announcement that Toni made for the benefit of those who will be seeing this online, and that is that next month's program will be 1 week early, second Wednesday, not the third Wednesday, November 13th, same place, same time, but 1 week early. And come to the health fair early and see the Da Vinci surgical system, which is really neat. Anyway, on to tonight. I have a couple of other things to say. Some of you have probably already noticed, if you've looked through the handout here, that the pages for the first speaker are in reverse order. So you can go from back to front there if you want to follow along. Okay, I will introduce our first speaker now and our other two speakers a little bit later. Our first speaker is David Kim. He's an otolaryngologist who treats a full spectrum of diseases affecting the head and neck, with a special interest in head and neck cancer. He attended UC San Diego for undergraduate and graduate studies and went on to receive his medical degree from Eastern Virginia Medical School. He then completed a residency in otolaryngology and head and neck surgery at the University of Nevada, Las Vegas, and subsequently a fellowship in head and neck oncologic surgery at Oregon Health and Science University. He grew up in Torrance, and he's a Torrance High graduate, I am told, and is excited to return to his hometown to serve local patient populations. Outside of work, he enjoys traveling, hiking, playing the piano, and spending time with family. Dr. Kemp.
All right, thank you, Frank, for the wonderful introduction there. Okay, so my name is David Kim, and I'm an ENT physician at Torrance Memorial Physician Network. And this evening, I'm going to be talking about dizziness, hopefully in a somewhat digestible form. So let's go ahead. First of all, I have no disclosure. All right. So dizziness is a pretty common problem in our society, actually, and it affects about 20 to 30% of the population in the country. In my practice, I would say it's close to about 30%. It's a little higher. And otherwise, in the balance disorders, it's the most common reason for doctor's visit for patients, especially somebody who's older than 75. And we all know that falls caused by dizziness and balance problems, it can cause a lot of complications and potentially morbidity as well. So we have to recognize what can cause all this dizziness. So before we go on any further, I want to talk about some of the anatomy. I know this sounds a little overwhelming, but I'm going to make it fairly simple. So if you look at the picture, there's outer ear, as you can see, and as you go in, there's an eardrum, and the space behind the eardrum is called the middle ear. And within this bone, we have inner ear, which contains cochlear, that's the hearing organ, and semicircular canals, utricle, and saccule. So semicircular canals, there are three components, anterior, posterior, and horizontal, and their job is to detect any angular or rotational motion. Whereas utricle and saccule, they detect any linear motion or gravitational pull. So maintaining balance is actually a pretty complex process. It does require a lot of inputs from different sources. So if you look at this diagram, it requires the angular information from semicircular canals and also linear information from saccule, and also proprioceptive information, which is a sensory information from joints and muscles, and also the vision and sounds. So all these inputs, they get integrated in the brain, which sends out signals to actually control your posture and also move your eyes as well. So whenever somebody comes in with dizziness, I always ask the patient, what do you mean by dizziness? So there are three subcategories of dizziness. So we have vertigo, disequilibrium, and lightheadedness. Okay, so vertigo, it's actually defined as a false sense of motion within a person's environment. So usually people say it's a spinning sensation or rolling, tumbling, or even rocking sensation. And usually it's due to some kind of dysfunction in the inner ear. And next we have disequilibrium, and it's essentially a difficulty maneuvering within a person's environment, but without illusion of motion. So people say, I feel imbalanced, clumsy, uncoordinated, and sometimes I have fear of falling. And this is usually due to some problems with central nervous system, which is the brain, and also neuropathy and even musculoskeletal problems. Okay, and lastly, we have lightheadedness, which is a wide range of motions and sensations, including ooziness, giddiness, feeling faint. Sometimes people feel like they're going to pass out pretty soon. So this sensation is caused by migraine, a lot of times vascular etiologies, and also medications, another common cause, and also metabolic and endocrine problems as well. So these are three main types of dizziness. So also when you talk about dizziness, we talk about central versus peripheral causes. So central means that it's coming from the brain, which includes cerebrum and brainstem. And peripheral means that it's from the inner ear problems. So that includes semicircular canals, utricle, saccule, and also nerve ganglia. So let's talk about some of the risk factors for dizziness. So age is important. People with over age 50, they're prone to having dizziness, and also female gender, and previous head trauma, and any medications, especially any blood pressure medications, and also medical conditions such as diabetes, hypertension, and also heart problems. It can cause dizziness in people. And also previous history of dizziness as well. And also stress and alcohol can make somebody prone to having dizziness. So let's talk about some of the peripheral causes, okay? So one of the most common causes is actually benign paroxysmal positional vertigo, better known as BPPV. And this accounts for about 40% of vertigo, okay? And this vertigo is actually from crystals, we commonly say, and also stones or ear rocks, okay? And usually this vertigo is very brief. It lasts seconds, less than a minute. And classically, people have a brief vertigo when they actually roll over in bed. Okay. So what's the cause? So essentially, it's from the displaced otoconia, which is a crystal in the inner ear. And otoconia, that's the proper term for those crystals in the ear. And otoconia is actually part of the normal ear anatomy. So people think that this is something you develop all of a sudden, but that's not the case. And also, what happens in BPV is that otoconia, it actually in the utricle becomes loose after some kind of head trauma, or it could be some kind of insult to the inner ear. And then, there's a subsequent head movement, and that displaces otoconia, and those stones become lodged in the semicircular canals. And usually it's the posterior canal that's affected. And this in turn stimulates the affected canal, and then that causes vertigo. So this is the picture of the inner ear. As you can see, this is the cochlea, and this is the semicircular canals. And as you can see, these are tiny crystals known as otoconia, and they're actually embedded into this membrane. And that actually connects with these nerve fibers, and that transmits information about the body position. So if you look at the picture at the bottom, and this is the actual image of the otoconia in the inner ear. So this is done with an electron microscope. And this is what happens with otoconia in the ear. So essentially, when you bend over, this otoconia actually, it pulls down on the membrane, and that sends the signals to these nerve fibers. And then that's how your body actually understands where its position is. So I want to talk about how BPPV actually occurs. So this person is sitting up, and this person actually have right-sided BPPV. And again, this is the inner ear. And if you look at the picture, there's this big round blue structure that's called utricle. Okay, and then these are white spots. Those are otoconia that we talked about. So what happens is that once they become loose, they settle down in this area. Okay. And then when the person lies back, then what happens is that this otoconia actually, from the utricle, it falls into this canal at the bottom. So this stimulates the canal, and you get vertigo when this happens. So I'm going to talk about different causes of vertigo. So we have Meniere's disease, and in this case, you have classic symptoms of recurrent spontaneous vertigo. And also you can have fluctuating hearing loss, especially at the low frequency. And you can have tinnitus or ringing sound. And lastly, you can have ear fullness. So you don't have to have all four symptoms to have Meniere's disease. You may have some of them, not all of them. So the cause of the problem is that there's something called endolymphatic hydrops. I know it sounds fancy. Essentially, it's an excessive buildup of the fluid in the inner ear, okay? And usually it affects only one ear, but sometimes it can be in both ears. Okay. And then we have this entity called vestibular neuritis. It's the inflammation of the vestibular nerve. And what happens is that you get sudden onset severe vertigo. And so people usually become very ill with vomiting, and also they say, I woke up with this severe spinning sensation. So this can last for days, actually. That's why people become very miserable from this. And the cause is usually some kind of viral infection. And people have done cadaver studies, and they saw that there's a herpes simplex type 1 virus. Usually it causes cold sores in people, and that's found in the inner ear. And there's also inflammation of the nerve, vestibular nerve. Okay? And then this entity can be preceded by an upper infection. Okay? And usually, the vertigo is self-limited in this case, but it can take weeks to recover. So a lot of people, they're very miserable for weeks. All right, and then we have what's called labyrinthitis. So it's inflammation of the balance and hearing nerves, actually. So this is similar to vestibular neuritis in that you get severe vertigo, but on top of that, you also get hearing loss and tinnitus. And a lot of times this is also caused by a virus, but it can be from bacterial infection as well. All right, and next we have superior canal dehiscence syndrome. So essentially in this case, you have a dehiscence or defect of the bone covering the superior semicircular canal. So this forms an additional window where the sounds can travel through. So in this case, people get vertigo induced by loud noises, and also certain activities such as sneezing, cough, and straining. And people can also have autophony, which is actually hearing your own voice very loudly. And some people can hear also footsteps. Okay. And there's also what's called perilymphatic fistula. It's a fracture of the inner ear bone, and it happens usually after ear surgery or some kind of trauma. And this leads to leakage of the inner ear fluid into the middle ear. Okay. And in this case, patient can get vertigo, ear fullness, and also fluctuating hearing loss. All right, so we have also autoimmune inner ear disease. So in this case, patient can have vertigo and hearing loss. And there's also a tumor that can involve the hearing and balance nerves. So it's called vestibular schwannoma. And it's a benign tumor, and people with this condition can have some vertigo in less than 50% of cases, and also hearing loss and tinnitus. And then you can also have a severe ear infection that can cause vertigo as well. And lastly, also, you can have trauma to the temporal bone, which has the inner ear. So you can also get vertigo and hearing loss. All right, so I want to switch gears and talk about some of the central causes, which is causes that stem from the brain itself. So there's something called migraine-associated vertigo. So it's vertigo with migraine symptoms, and it's seen about 25% of patients with migraine, and it is the second most common cause of recurrent vertigo after BPPV. And usually patients present with migraine symptoms during vertigo episodes. So there's also headache, photophobia, which is light sensitivity, and phonophobia, the sound sensitivity, and vision change as well. And then also there are life-threatening causes of vertigo, and I want you to be aware of these symptoms. So stroke and mini stroke, it can also cause vertigo and imbalance. But patients with these conditions, they present with additional neurological signs such as weakness and slurred speech. And there's also intracranial hemorrhage called epidural and subdural hematoma, especially after some kind of head trauma. So you can actually get a fall and then get into a car accident and then develop these bleeds. And then in this situation, you want to watch out for any severe headache or change in mental status. So if you suspect any one of these conditions, I would go ahead and call 911 or go to the emergency. Okay. All right, so more central causes. So there are also some degenerative neurologic diseases, such as multiple sclerosis, which leads to the loss of motor and sensory function. And we all know about ALS or Lou Gehrig's disease. It can also cause vertigo and dizziness in people. And Parkinson's also another culprit as well. And then any infection in the brain, it can also cause vertigo, such as meningitis and encephalitis. Okay. And concussion from trauma or playing sports, you can get transient vertigo. Usually, they tend to last days, but eventually they resolved. All right, so another big player is actually medications. So there are a lot of medications that can cause vertigo and dizziness in people. So one of them is actually aminoglycosides, which is a class of antibodies, and they're known to be toxic to the inner ear. So some of them include gentamicin and neomycin. You may have heard of some of them. And these can cause vertigo and hearing loss and ringing sound. And also some of the chemotherapy drugs, such as cisplatin, can also cause vertigo and hearing loss. Okay. And then there's also aspirin, ibuprofen. Those medications can cause vertigo, but not all the time. Okay? And then a lot of the blood pressure medications, such as beta blockers and water pills, they tend to lower your blood volume, and it causes lightheadedness and sometimes fainting spells. Okay? And also we have antidepressants, such as Prozac and Zoloft. So those things can also cause lightheadedness and sometimes even ataxia, which is impaired coordination. All right, so more causes here. So, people with heart problems, they can have lightheadedness from different causes, actually. So if you have, let's say, atrial fibrillation or heart failure or any heart valve problems, you can have lightheadedness and imbalance problems. And also there's an entity called orthostatic hypotension. It's a case where you have a drop in blood pressure when you either stand up or get up because of inadequate composition within the body. And then also when you have a hole in your eardrum, you can also have vertigo from the exposure to outside air. And then nowadays a lot of people have allergy problems, and this congestion in the nose, it can also cause eustachian tube dysfunction. So it's the tube that connects your middle ear and your nose. So this creates negative pressure in your middle ear, and in turn this causes dizziness in people. All right, and also any change in surrounding pressure. Let's say if you're a diver, when you get up to the air, into the surface too quickly, and you can have vertigo. Also flying, it can cause vertigo as well. And hypoglycemia, again, low sugar, it can cause lightheadedness in people. And dehydration, I always tell patients to drink plenty of liquids. And also anxiety can cause lightheadedness. And people with also neuropathy in diabetes patients, it can also lead to impaired sensory input, and then you get imbalance. And people with arthritis also can have unstable gait. All right, so the question is, how do you make a diagnosis in this case? So we have a bunch of information that we have to collect. But first of all, what I care most is actually history, because a lot of times history alone can tell you a lot of diagnosis. So when I first see this patient with dizziness, I always ask about, is it vertigo, is it imbalance, or is it lightheadedness? And also I ask about duration of vertigo. So it could be seconds, minutes, hours, or days. And the pattern, is it continuous or episodic? And any relationship to body position or posture, those are all important information. Okay. And also I ask about any hearing problems or any ringing sound, because some of the diseases such as labyrinthitis, they can have hearing problems along with vertigo. And I also ask about any precipitating factors such as trauma prior to the onset, or any recent illness, any sick contact, any medications they took recently. So these are all important information. And also I ask for a thorough medical history. So ask patients about any migraine, any endocrine problems, any cancer, heart problems, etc. So when it comes to vertigo, the duration of symptoms are very important, because even looking at duration only, it can tell you what the diagnosis is a lot of time. So when the duration is only seconds, less than a minute, usually it's a BPPV, but it can be also paralymphatic fistula, which is the breakage in the bone, and also superior canal descent syndrome. And then if it's, let's say, minutes to hours, then that's more classic for Meniere's disease. And sometimes you can get this with paralymphatic fistula. And when it's days, that's usually either vestibular neuritis or labyrinthitis. Okay. And sometimes the vertigo can vary in duration, so it can be in seconds one day, but days for a couple of weeks. That tells me it may be possibly migraine-associated vertigo. Sometimes it could be psychogenic or psychiatric origins. So after I get the full history, I always do a full examination. So I look at the ears, make sure that there's no infection, there's no hole in the eardrum. And also, the eye exam is very important, because I always look for any nystagmus, which is an involuntary rhythmic eye movement. So whenever there is one, it tells me there is some kind of imbalance problem. And also, you want to do a complete neurological examination. And also, I like to listen to the patient's heart because sometimes patients with AFib, they can have lightheadedness as well. And also, I listen to their neck sometimes because people with carotid artery stenosis, they can have a neck bruit, which is a turbulence from the blockage in the carotid artery. And I do some specific balance testing. So one of them is actually, it's called Fukuda stepping test. So essentially, I have the patient to raise their arms with eyes closed, and then I have them kind of march in place without going forward. And then I do about 100 steps. And then what happens is that people with balance weakness, they turn to one direction versus the other. So if you look at this diagram, this person actually is deviating towards the right side. So that tells me this person has some sort of right-sided vestibular hypofunction. All right, another test I like to do is actually, it's called head impulse test. So this test checks what's called a vestibular ocular reflex. So this reflex allows a person to maintain eye fixation when they turn the head. So what I do is I have the patient focus on my nose, and then I turn their head quickly while they maintain the gaze. So in people with normal reflex, what happens is that when you turn their head, they can maintain the gaze straight ahead. But people with abnormal reflex, what happens is that if you turn their head, the eyes also move with the head. But then within seconds, they try to look back to catch up. So that's called saccade, which is a corrective eye movement, and that indicates some kind of balance problems. So in this case, since we did the right side, this patient has right-sided hypofunction. And also, I do test for BPPV. It's called Dix-Hallpike test. And essentially, you have a sitting patient in front of you, and then you have them look at you at about 45-degree angle. And then I lay them down quickly with head extended backwards. And then you look for any eye movement. So in Dix-Hallpike test, the positive test would be where patients has this nystagmus. And it's a specific pattern of eye movement. So it's got an upbeating motion, and also it tends to roll towards the affected side. So in this picture, I'm testing patient's right side. So the positive test would be eye moving this direction and in a counterclockwise direction. So it'll be kind of going this way. So that would be a positive Dix-Hallpike test. Okay. And also, I like to do a hearing test on everybody because a lot of times in hearing and balance, they're intimately related. So a lot of problems with inner ear, you have some hearing issues. So Meniere's disease can have hearing loss, and labyrinthitis also have hearing compromise. So I like to always do a hearing test. Okay, so there are more kind of advanced balance testing available. So one thing I do is I order a video nystagmography. It's called VNG. So it's usually done by an audiologist who also does a hearing test. So what it does is it measures nystagmus, the involuntary eye movement, and we essentially put infrared goggles on the patient's face like this. And then what you do is you have them kind of follow the dots on the computer screen, and also you can do this Hallpike test with goggles on like this. And lastly, we also do caloric test, which is applying warm or cold air or water into the ear, and then you check their eye movement. So you can also do VNG with a rotary chair. This looks like a kind of fun test to do. But usually this is only available at a big academic center, and I've now seen this in these communities, so just something to think about, yeah. All right, so there are also other more advanced tests. I'm not going to go into too much detail because it's kind of beyond the scope of this talk. So there's something called electrocochleography. It essentially records electrical potentials of the cochlea. So this test is useful for diagnosing Meniere's disease. And also there's a test called VEMP that essentially checks the function of saccule and utricle. And it can be used for patients with superior canal descent syndrome or Meniere's disease. And also I do other tests. So people with any heart problems, I tend to order EKG, or they go see their cardiologist and get echocardiogram done. And sometimes I also do carotid artery ultrasound. And if you suspect any central causes, then I also order MRI or CT brain. And if there's any trauma to the head, then we get CT temporal bone, which is the bone of the inner ear. Okay. And unfortunately, there aren't many blood tests for vertigo. But if somebody has autoimmune problems, then there's a test for the antibody to the inner ear protein. All right. So the question is, how do you treat this? So, there are some specific treatments for different conditions. So for BPPV, there's a maneuver called Apley maneuver, but I'm not going to go into too much detail because I think Timothy Baker and Melissa Shintani, our physical therapy colleagues, they'll talk more about that in a bit. So I don't want to steal their thunder. So, all right. So let's say if you have Meniere's disease, then there are different treatment options. So usually you like to restrict the salt intake, so you recommend low salt diet. And also you use diuretics or water pills to excrete all the extra salts. And also sometimes you can inject steroid through the eardrum. It's called intratympanic injection. And also you can inject gentamicin, which is a toxic antibiotic. So what it does is it kills off the balanced organs, but also it can destroy the hearing as well. So it's not the first line treatment, of course. And there are also surgeries, so you can do decompression surgery. And there's also labyrinthectomy, which is a procedure where you take out the balance and hearing organs. And it's a very destructive surgery because it destroys your hearing. So this is usually a last resort kind of thing, So, okay. And there's also what's called beta-histine. So this is a histamine analog. And what it does is it can improve the blood flow to the inner ear and also reduces the fluid pressure. So it's been around for a while, but it's been only approved in Europe and Canada, but not in the U.S. So I know a few patients who actually go up to Vancouver every couple of months to get this. All right, so let's say if you have a vestibular neuritis or labyrinthitis, then since this is an inflammatory problem, we tend to give steroids, either orally or through the eardrum. And the studies have shown that this actually enhances the recovery. And also, people get antiviral medications because we thought that this is probably from a viral infection, but studies have now shown the benefit from antiviral medication. So I don't usually give it to patients. And let's say if you have migraine-associated vertigo, then usually we like to give them prophylactic medications to prevent episodes, so calcium channel blockers, beta blockers, and sometimes even antidepressants and anti-seizure medications. Let's say if somebody is having an active episode of migraine, then we do give triptans. One of them is actually Imitrex. Some of you may have heard of it. And let's say a patient has some kind of infection, either ear infections or meningitis, then you give antibiotics, of course. Okay? And if the patient has a tumor, the vestibular schwannoma, then there is a surgery, and also there's a stereotactic radiation therapy available. All right, so how do we treat vertigo medically? So one of the medications that people like to use is called meclizine. I'm sure some of you may have taken it in the past. So essentially it's an antihistamine, and it's used to treat motion sickness. And probably almost everybody who ends up going to emergency for vertigo, they end up getting this medication as well. So what it does is it depresses the vestibular stimulation, but of course there are some side effects. So you can get drowsiness, dry mouth, and confusion, and even worsening dementia, especially in geriatric population. So you have to use this carefully. Okay. And the downside is that it tends to slow down the vestibular recovery because it only suppresses your vertigo. So what I tell my patients actually is sometimes you have to feel dizzy to let your body kind of compensate for it. So I tell patients to take meclizine only if you really need it. Okay. And also there are other antihistamines. You've heard of Benadryl and Dramamine. And there's also a scopolamine patch, and you change it every 3 days, but you can still get dry mouth and blurry vision from this. Okay. And there are also anti-nausea medications such as Zofran, Reglan, and Phenergan. Okay. And also people have tried anti-anxiety medications such as Ativan, Xanax, and Klonopin as well. So there has been some new developments in terms of medication options. So there's this medication called pentoxifillin, and what it does is it reduces blood viscosity, meaning that your blood becomes thinner, and it improves the blood flow to the inner ear. So right now there's a clinical trial going on this. And also there's a compound called Auto-140, and it's essentially a sustained release form of the dexamethasone, which is a steroid, and you actually inject it through the eardrum for people in Meniere's disease. And again, there's a trial going on right now on this. But unfortunately, overall, there has not been any major groundbreaking treatment options, so things have been kind of slow at this point. All right, so another important aspect is, of course, balance therapy. Also, we call this vestibular rehabilitation. So it's done by physical therapy, and of course, our physical therapy colleagues will talk more about this in a bit. Okay. All right, so I also send some of my patients to other specialties as well, especially if you suspect any central causes like migraines or multiple sclerosis, then we send these patients to neurology. And also, if there's any concerns about heart problems, I send them to cardiology. And patients with any carotid artery problems, they end up seeing vascular surgery. So in summary, when it comes to vertigo or dizziness, I think accurate history is the most important for diagnosis. And I want you to also recognize the difference among vertigo, imbalance, and lightheadedness. And also be able to recognize some of the common and also dangerous causes of dizziness as well. And medications can be helpful, but only in certain settings. And again, vestibular rehabilitation is an important part of the overall treatment plan. Okay. All right. Thank you.
Thank you, Dr. Kim. I had no idea so many different things could cause vertigo. It's not surprising that many people suffer from it if there are this many causes. Well, our next speakers will sort of present make a joint presentation. First of the two to speak will be Melissa Shintani. She began her education at UC Irvine by completing her undergraduate degree in biological sciences in 2012. She continued her academic career at USC, where she attained her doctorate of physical therapy in 2017. During her final year of graduate school, she completed long-term clinical affiliations, working with both orthopedic and neurologic populations. She began her professional career pursuing her passion for vestibular therapy, and now treats a variety of neurologic and musculoskeletal injuries. And Timothy Baker received his doctorate of physical therapy from Arcadia University in Glenside, Pennsylvania in 2016. He completed his undergraduate degree in exercise physiology with minors in both biology and psychology at DeSales University in 2012. His physical therapy practice specializes in outpatient orthopedics and vestibular rehabilitation. He is a New Jersey native and now resides in the South Bay. So let's welcome both Melissa and Tim.
Hi, everyone. Thank you so much for coming tonight. Both Tim and myself are very passionate about this topic, so we're very excited to be here. We feel that not enough people know, A, the causes of dizziness, and B, that there's something that could be done that could potentially help reduce your dizziness, improve your quality of life, lower your risk of falls. So we'll get going here in a second. So what we're going to talk about today is the prevalence of dizziness and falls, the risk factors for falling, which is a little bit different from what Dr. Kim had said about the risk factors for dizziness. We'll reintroduce the vestibular system, talk more about BPPV, which is positional vertigo, and discuss vestibular rehab and treatments and ways to reduce your risk of falls. So the good thing is his presentation and this entire topic can be very complicated, so it'll be a little bit good to review. Vestibular disorders affect more Americans than type 2 diabetes, asthma, fibromyalgia, and celiac disease combined. That's a pretty powerful statistic. 80% of people with vertigo have an inner ear disorder. And again, vertigo is the sensation of the room spinning. Okay, 35% of adults aged 40 years or older in the US have experienced some form of vestibular dysfunction. And this is very important because if you are dizzy, it could increase your risk of falls, and falling can have a huge effect on people. 1 in 4 older adults will fall this year, and 1 in 5 of those falls could result in a serious injury. So if you land on your hip, it could cause a hip fracture. If you land and hit your head, it could cause a brain injury. And unfortunately, falling once could double your chance for falling again. So it's really important that we're going to talk about the risk factors for falling. Okay, so older age is a known risk factor, a previous history of falls. Something really interesting is that a fear of falling will actually increase your risk of falls as well. The next are a little bit more obvious: weakness in your legs, vision changes or poor footwear, postural hypotension. That was what Dr. Kim referred to when your blood pressure could lower when you change position. So an example would be you sit up too quick and you feel lightheaded for a moment. Some people that have a more severe version of this may feel dizzier. Medications, tripping hazards at the home, and vestibular dysfunction. So just to review, we've already talked about this. This is the inner ear, and this down here is the cochlea, which he discussed is more for hearing. And this looped portion up here is responsible for balance. So when you hear the term vestibular, you should be thinking that it's the part of your body that's trying to maintain equilibrium. So the vestibular system in this portion here is constantly measuring head motion. So an example would be you're looking up or looking down, right or left. Those are all times when your inner ear is being activated. Okay, so here's why that's really important. You have 3 systems in your body that are contributing information to your brain to let you know where are you in space. The first is your vision. That's the most obvious one. That's the one that's giving your brain information relative to the environment. So a great example would be if you're walking in the dark or you wash your face in the shower and you close your eyes. For a quick minute, you might feel a little bit unsteady or potentially dizzy. And the reason for that is that you are decreasing the feedback here, and you have to rely more on these bottom 2 in order to maintain your balance. So the second system is your inner ear, which we just talked about. Some of you out there may be able to relate to feeling dizzy or unsteady if you turn your head too quick or you do a quick pivot turn. That would be an example of when your inner ear needs to be working fast and strong, and if it's not getting the accurate feedback to the brain, you could have some type of symptom. And then finally, your joints, muscles, and actually skin should be on there too. It's constantly giving your brain feedback regarding the sensation of touch. So if you walk and you touch along furniture, just touching it can help keep your balance. Not necessarily like you're holding on to maintain. If you do have peripheral neuropathy, which is the loss of sensation in your feet, so you might have numbness or tingling in your feet, that will make a huge role because now you are decreasing the feedback from this system and you're forcing your body to rely on these top 2 systems. And that in turn can cause balance problems along the way if you are not using both of these systems very well. Okay, so from that point, your brain will take all of the information from these 3 systems, send it to the brain, and it'll integrate like a computer to determine what is your body positioned and what are you doing at that moment. If it senses that you're about to lose your balance, it'll send a signal to the muscles to make some type of reaction. So an example could be you reach to grab something to catch your balance, or you might take a step, right? That would be a reaction that we would want people to have. And from there, you have this continuous cycle. Okay, so this cycle is constantly working when you're moving, and this is where, as physical therapists who do vestibular rehabilitation, we are trying to figure out where in this cycle are you having the deficits. Wherever the deficits are, we would try to intervene in order to improve your balance. So a good example would be if it's on the strength side, we might give you strengthening exercises to try to get your legs stronger. If it's on a vestibular disorder, like an inner ear problem, like what Dr. Kim was referring to earlier, we would do vestibular rehabilitation. So it's a specialized form of therapy. It's aimed at reducing all of these symptoms here. Okay, if you do have a vestibular disorder, depending on what type, the brain, it's constantly trying to adapt. So there is a term written here called vestibular compensation, and I think Dr. Kim referred to that earlier. It's your brain and your body trying to recalibrate this balance system to come back to create some sense of equilibrium. Okay, this can occur naturally, but if it does not, then you can use vestibular rehabilitation to help kind of kickstart the process and speed up the recovery. Okay, so what do vestibular therapists do? If you were to come in and see Tim or myself, we would do a comprehensive history based on, again, this slide here to figure out where is the impairment. So we would do a thorough history, we would do an ocular motor exam, also the eye test. We would check strength and sensation. We would watch how you walk, called gait analysis. We would do balance testing if necessary and positional testing if necessary. And we're going to talk about these bottom two in a little bit more detail. Okay, so this is a great balance test called the timed up and go. It's one that we would use in the clinic. It's amazing because it has very little equipment. Tim's going to demonstrate. It's a very simple test. It's awesome because it looks at functional mobility. So it's your ability to stand up from a chair, walk 10 feet, 3 meters, towards a target, walk back around and have a seat. So gait speed is really important to determine how well someone can keep their balance.
I apologize that they saved the worst speaker for last. So if anyone wants to get up and beat the traffic, now's your chance. But what I'm going to start talking to you about is we're going to revisit that benign paroxysmal positional vertigo, or because that's a mouthful, what we refer to as BPPV. And if we break that down, benign means that it is not life-threatening, which should be a relief. Okay. Paroxysmal means that it comes in sudden but brief spells, and brief is the key here. Positional means that it occurs with changes in position. So common reports would be, when I roll over in bed, I feel dizzy. When I look up to reach for something out of the cabinet, I feel dizzy. Or when I bend down to pick something up off of the floor, I feel this spinning sensation. And vertigo, again, is that rotational or spinning sensation of ourself or the environment around us. With BPPV, we have those balance sensors, or those otoconia, those crystals that sit on these yellow jelly bean looking things here, okay? And for when we tilt our head, these crystals fall into these, what should just be fluid-filled canals, as Dr. Kim touched on earlier, okay? And when these crystals fall into that fluid-filled canal where they're not supposed to see, or supposed to be, they send faulty signals to our brain telling us that we're spinning. And the way that I like to describe this to my patients is it is positional. So if you were to shake a snow globe, the glitter in that snow globe would eventually settle to the bottom. And that's what happens with the vertigo. Once we stop changing position, the crystals will eventually settle and we'll stop feeling that spinning sensation. And that's why, because those crystals have come to a halt. And just to put this image into perspective, because it's very blown up here, the cochlea, so the hearing and the balance system, are about the size of a dime. They're embedded in our temporal bone. We have one in each ear, the right and the left. You can't see it, touch it, or feel it, And these otoconia, or the calcium carbonate crystals that we refer to, are about the size of dust particles. So they're very small, okay? And you're probably wondering how we determine if these when these dust-sized particles are out of place. Well, you've come to the right lecture. So if you were to come into us with a script for vertigo, the gold standard for assessment of this positional vertigo, or BPPV, are the Dix-Hallpike, which Dr. Kim touched on a little bit earlier, and the supine roll test, okay? When we perform these tests, though, what we're trying to decide is if it's the right or the left ear, okay? So you're probably wondering, why don't I just jump on Google, and I've heard of the Epley maneuver, why don't I just see how I do it, okay? When we're doing this assessment, we're using the Dix-Hallpike, and we're trying to determine if it's the right or the left ear that is involved, okay? We need to decide which of these three canals the crystals have fallen into, okay? The posterior canal back here is the most common, okay? But we also have the anterior canal and the lateral or the horizontal canal, and the crystals can fall into any of these here, okay? It's estimated that over $2,000 is spent per dizzy patient to come up with a diagnosis of vertigo, and over 65% of dizzy patients will undergo potentially unnecessary diagnostic testing and treatment interventions. For instance, an MRI or a CT scan. So as Dr. Kim had mentioned earlier, just taking a thorough history can lead us to believe that it is just that benign crystal issue in the inner ear. We do this testing and we figure out which canal is involved. So the Dix-Hallpike test, we lay the patient back quickly with their head rotated to the left or the right side, okay? And we're watching for the direction of the eye movement, okay? That direction of the eye movement tells us if it's the right or the left ear that we're testing. We're figuring out if it's the anterior, posterior, or horizontal canal, and if that crystal is stuck to somewhere in the canal, or if it's free floating. And that helps us to determine which repositioning maneuver that we're going to use to get those crystals to float back into place. So the most common that some of you might have heard of before coming to this lecture is the Epley maneuver. And the literature has shown success rates when those crystals are out in that posterior canal of above 90% success rate within 1 to 3 treatment sessions. So we see very good results with this maneuver when we can figure out where that crystal is and treat it. And again, what we're trying to do is it's that semicircular canal, so it's a half circle, and we're trying to reposition the head in each step to rotate that crystal around, and the last position right here being falling back onto that gel layer where the crystal should live, okay? So when we're in each position, like that snow globe analogy, we're waiting about 30 seconds to a minute, sometimes longer. We're waiting for those symptoms and those eye movements to stop, and that tells us that those crystals have settled, and we can turn the head to the next position to float that crystal around the canal. Another common exercise that we use in vestibular rehab are gaze stabilization exercises. Dr. Kim had talked about vestibular neuritis and that head thrust test. So if we're shaking that head and they're not able to maintain focus on our nose, then one of the exercises that we might provide is a VOR exercise. The goal, that's a common exercise prescribed for patients with vestibular function who are complaining of jumpy vision while they're moving their head. They're not able to keep their eyes on the page or on the object that they're trying to focus on. So they're getting some jumpy vision because of that vestibular ocular reflex, or the VOR. So the goal of the gaze stabilization exercises are to decrease dizziness by improving control of the eye movements so that our vision can be clear while we turn our head. So I'm going to go over an example of this exercise right now. So again, the vestibular ocular reflex We abbreviate it VOR. So I'm going to have everyone stick their thumb out in front of them, and you're going to focus on your thumbnail. Okay, and then keeping your eyes focused on your thumbnail, you're going to turn your head side to side as if you're saying no, while maintaining focus on your thumbnail. And that nail should stay in focus. It shouldn't get blurry. It shouldn't get double or jumpy. And if that's happening, you want to try to slow the motion to keep it in focus. So initially when we're starting out with these exercises, we might have to go a little bit slower, okay? Because again, we're trying to retrain that vestibular ocular reflex to catch up, okay? So initially it might be strong. So similar to if you were to have a weak muscle, you're trying to strengthen the muscle that's weak. We're trying to strengthen this reflex that's weak after a diagnosis like possibly vestibular neuritis, where that vestibular ocular reflex has been reduced. And you can do this up and down as if you're saying yes as well, still trying to keep your eyes focused on that thumbnail. Or you can write an X or a dot or any type of mark on a Post-it note and hang it on the wall. A lot of times in therapy, we'll do standing balance exercises while we're doing the VOR to kind of incorporate both. Another one which takes a lot more coordination and is a little more challenging is VOR times 2. And that's where you would stick your thumb out in front of you. Make sure you don't hit your neighbor here, because your thumb is going to go opposite direction of your head. So it should only be about a 12-inch movement of the thumb. Okay, the thumb should always stay within your line of vision. Okay, it should never go out of your peripheral vision there. And you're trying to maintain focus on that target. It takes a lot more coordination than just the VOR times 1. So some of the patients might not even get to that second step, because there's ways to progress just that VOR times 1 if they're having difficulty with the coordination. Next, we're going to talk about some simple balance exercises which can be performed at home without any equipment. Oh, there we go. And the goal of this is to improve steadiness and reduce your overall fall risk. Okay, so the first of which is called a heel raise or a toe raise. So I'm going to have everyone stand up at this point, and we're going to practice this. If you don't feel safe doing this, I'm going to ask you not to participate. Okay. If you need to use the backrest of the chair in front of you, you can have a hand on there for safety, okay? But the first exercise we're going to do is just raising up onto your tippy toes. And I'll have everyone do that 5 times, and you should feel the muscles in the back of your lower leg or your calf muscles working there, okay? And then I'm going to have you rock back onto your heels and pull your toes up. And you should feel the muscles in the front of your shin working there. Okay? And the reason that we do these exercises is because when we look at our balance, if you look at this ice cream cone looking thing here, okay, that's kind of how our balance works. It's a ground up approach, okay? So once we start to lose our balance a little bit, we pull in what we call an ankle strategy, okay? So those ankle muscles that you were just working with that exercise are the first muscles to kick on when we feel a little bit unsteady or imbalanced, okay? If it goes outside of the what we call cone of stability here, we might have to pull in a hip strategy. So we get a little hula dancing going on if the ankle can't correct for that imbalance, okay? And then lastly, if it goes outside of that cone past the hips, we use a stepping strategy, or we need to grab onto something to keep our balance to prevent us from falling. So that's one of the reasons that we strengthen our lower leg muscles. And one way to progress this, if both of those were a little bit easy, and again, you want to do these for repetition, not just 5, okay? But one way to progress this would be to rock from heel to toe, back and forth, to work on weight shifting. Okay. The next exercise, and I'm going to ask for some audience participation. So how many times do you think the average person stands from a chair on a daily basis? Yell out some numbers. 5, 10, 20, 50. Okay. on average, it's 45 times, okay? So one of the exercises that you can do at home is just practicing that standing from a chair, okay? And the easiest way to do that is to use your legs and both hands at the same time. So I'll have everyone stand up with their hands pushing from the chair and using their legs. Okay, so that's probably easy because you're using all four extremities, both arms, both legs, okay? The next progression would be to use one hand on the chair, but we'll skip that and just jump to one of the harder ones, okay? One of the toughest ones would be to not use your hands at all. So go from using two hands to push up from the chair and just try to stand without using your hands. And you could feel those leg muscles work a lot harder, okay? So this exercise, again, you're gonna do it for repetitions, okay? So 15, maybe 20 repetitions at a time until you're really feeling the burn in your legs, okay? And this is gonna work on leg strength and endurance, okay? So if you have that lower leg weakness, this is something that we would want to address because the weakness could increase your risk for falls. And then the last exercise that can be practiced at home is static balance. And this is the progression here. So I'll have everyone stand. And again, if you don't feel safe, I'll ask you not to do it. Or if you need to hold on to the chair in front of you for safety, that's okay as well. So you're going to stand with your feet about hips width apart. And this is the easiest way to maintain our balance by increasing that base of support. So the distance that our legs are underneath us. Okay. To progress it, you would bring your feet side by side so that they're touching. And that's going to narrow your base of support, and that's going to make your balance a little bit harder. It's going to be tougher to maintain your balance. And then we have semi-tandem or half tandem, where your heel of one shoe will go into the arch of the other shoe so that you're standing halfway heel to toe. And that's going to challenge your balance a little further because, again, we're still narrowing that base of support that we're standing on. And then the toughest, this is how I spent my last Friday night walking the line with the police officer in Torrance. No, I'm just kidding. But that's one of the toughest ones would be to stand heel to toe and just try to hold your balance there. And you can feel, again, only do this if you feel safe, okay? You can feel that there's a lot more sway when you're narrowing your stance. Okay, and then one of the most challenging would be to stand on one leg, either the right or the left. So when you're doing these tandem balances, you always want to do it with the right foot in front and the left foot in front because there usually tends to be a stronger leg that we rely on. So you want to practice both. All right, and again, with these balance exercises, you want them to be challenging. Okay, that's how you're going to see improvements, but at the same time, they need to be safe. So when I prescribe these for my patients at home, I usually have them do them at the countertop in case they need to grab onto something to maintain their balance. And another way they could do this is to kind of box themselves into the corner without touching the wall, okay, because you're trying to hold your own balance, but have something sturdy like a nice firm chair in front of you where if you were to lose your balance forward, you could catch yourself on the chair, okay? And then ways to progress this would be, again, to remove that vision, so close your eyes, okay? And then you're relying on your feet being able to feel the floor and your vestibular system, sensing where you are in space. And then another way that we progress our static balance exercises is through turning our head side to side. So I mentioned earlier, sometimes we'll do that VOR exercise in one of these standing balance positions. And we talked about this. So what can you do to reduce your fall risk? Okay. One of the first things to do would be to talk to your doctor and schedule that annual physical exam. Talk to your doctor and let them know if you've fallen in the past year or if you have a fear of falling, because remember, those are two risk factors for falls. They won't know unless you tell them, okay? See your eye doctor. Make sure that your prescriptions are up to date. As we age, we see an increased incidence of cataracts or glaucoma, okay? So we want to make sure that we're seeing our eye doctor regularly so that our vision is up to par, okay? Because that's one of the strongest influences of our balance and reducing our risk of falls is that vision. And then a lot of times if you have the numbness and tingling in your feet or the neuropathy, you should be followed by a podiatrist or a foot doctor, and they can recommend the proper footwear for you, okay? And then let them know if you're feeling dizziness or imbalance, because that's an internal feeling that you need to verbalize to them because they won't know otherwise. Again, this is a team effort. And then have that doctor review your medications, especially if you're getting prescriptions from multiple doctors. Some of these medications, as Dr. Kim talked about earlier, can have side effects, and some of them can even have interactions with the others. So if you're followed by a couple of specialists, make sure that you have a gatekeeper. So talk to your primary care physician or your pharmacist to make sure that some of these medications aren't interacting and causing dizziness or imbalance. The next thing you can do is to make your home safer. So remove tripping hazards from the floor or the walkways, okay? So that would be papers, books, cords, that t-shirt that you came home from work and threw into the corner because you missed the hamper. You don't want to trip over that when you're getting out of bed to go to the bathroom in the middle of the night when the lights are dim and you're just kind of in a fog from just waking up from sleep. Remove any area rugs or throw rugs, okay? Like you see here, the walker or even your toe can catch on the corner of that rug, and that can be a huge tripping hazard, okay? Use non-slip bath mats in your tub, in your shower, and even outside of the shower to make sure that you're not slipping. Improve the lighting in your home, okay? So use night lights. This day and age, we have night lights with sensors. So if you don't like to sleep with any lights on, prevents you from falling asleep like myself, when you stand out of bed, that night light will detect kind of when it senses motion, and it'll turn on for you. Okay, and you have them in your bedroom as well as your bathroom, especially when you're getting up in the middle of the night and you're still kind of in a daze from sleeping. Install grab bars in your bathroom, in the shower or next to the toilets, okay? And then, again, you want to wear well-fitting shoes with good support so that you're not tripping over your footwear. And then lastly, this slide got a little messed up, but movement is medicine, okay? So stay active. The American Heart Association recommends that we exercise for 30 minutes a day at a moderate intensity, 5 days out of the week, okay? But even if you're not there yet, start small, okay? Gradually increase that activity over time, and even as small as spending less time sitting, okay? Even small changes can help to reduce the detrimental effects of a sedentary lifestyle, okay? Walk or exercise with family and friends. It makes it a little more fun. And then join any community exercise classes, such as Tai Chi or chair aerobics or balance classes. The best exercises are the ones that you'll do. So find something that you enjoy doing, and I challenge all of you to find this and go out and do that so that you can live a happier and healthier life ahead. Thank you. And then this is a nice patient-friendly educational resource, vestibular.org, and it talks a lot about the vestibular disorders and balance disorders that we discussed. It's a nice resource for the community.
Thank you, Tim and Melissa. We'll have about a 5 to 10 minute break now. The members of the Miracle of Living Committee will circulate through the audience, passing out paper and pencils and picking up written questions to be asked after the break. So we'll now have a brief time out. Thank you. All right, I'll take that. What? I don't have them, but this lady here does. Folks, could we take our seats now? We've got tons of questions and we need to get started. please take your seats so we can get started with the questions. Okay, let's get started here, folks. All right, let's begin here. Okay, I will read the question and then let any of our panelists who wishes answer it. Let's begin with this one. We commented on how many different things can cause dizziness. One that was not mentioned, that we'll ask about now, can vitamin deficiency cause dizziness problems?
Well, vitamin deficiency itself doesn't cause dizziness, but some of the vitamins that can contribute to health of your central nervous system, brain system. So folate, all those vitamins. It can, if you're really deficient, it can cause some kind of imbalance problems down the road. But it's been seen rarely. So you have to be really deficient in those vitamins, but otherwise, usually it's not a main player. But it's possible, so.
How do beta blockers affect balance?
So beta blocker, what it does is it does slow down your heart rate and also lowers your blood pressure. So what it does is that if you take it, too much of dose, sometimes it can cause a severe drop in blood pressure. And what happens is that means there's not enough blood going to your brain, so you can get vertigo, imbalance. Sometimes you can have a fainting spell. So that's why you have to be on the right dose.
What ordinarily causes an ear infection? What are common causes of ear infections?
Right, so when you say ear infection, there can be a lot of different definitions. So in the ear itself, there's the outer ear in the ear canal. Also there's the middle ear, which is the space behind the eardrum. So the outer ear itself, usually we call that swimmer's ear. So it can be from the swimming or some kind of trauma to the ear canal. The middle ear infection, a lot of times it can be from some kind of eustachian tube dysfunction. So whenever you have really bad allergies, sometimes there's not enough air going into your middle ear, so that can cause a fluid buildup in the middle ear, and in the long run, that can become a source for an infection. And especially we talked about inner ear infection as well. So you can have labyrinthitis, which is an infection that affects the inner ear itself. So you can have, like I said, vertigo and hearing loss.
Can earplugs dislodge crystals? And also, does being susceptible to car sickness or seasickness indicate a tendency to have vertigo problems?
Right, so earplugs themselves, it's not really anywhere near the inner ear because there's an eardrum between your outer ear and inner ear. So earplugs themselves, it's not going to really dislodge the otoconia, the stones. But let's say if you have earplugs for a prolonged time, it can cause some imbalance in your middle ear pressure, and that can cause some dizziness in people. But usually it's not the main cause of dizziness.
Why does vertigo sometimes last much longer than other times, several days versus a single day, for example?
Right, so a lot of times, it all depends on triggers. So let's say, if you have constant, movement, it can prolong the vertigo episodes. But other times, like I said, there is a form of vertigo that can last, sometimes minutes on one day, but then it could be days. And like I said, sometimes vertigo from migraine can present like that. And also any, psychogenic causes, they can also present as kind of variable vertigo duration. So.
How long will vestibular neuritis symptoms last? Months, years? Can they last forever?
So usually, in my experience, I would say they tend to be worse the first 2 weeks after the onset, but patient usually feel better after 3 to 4 weeks. it all depends on individuals, of course. But I would say patients feel much better by second month or usually.
I can touch on one more thing. If you are having a neuritis and it feels like the vertigo is maintaining, I would highly recommend A, talking to your doctor, B, potentially seeing a physical therapist. But the exercise that Tim had showed about these eye exercises, where you look at the target called the VOR exercises, I would try that and try to do it within your reason, so don't push yourself too much, but try to get that inner ear eye reflex working to see if that can help compensate. Because that's actually a big thing, is if you don't move and you keep your head still and you do have a neuritis, you're actually not letting your brain get the opportunity to compensate back and recover. So that's one of the big things as well.
And I'll just say, in the clinic, we can tell when patients are and are not doing their homework, their VOR exercise, because they're the ones that are taking longer and they come in and ask us why they're still feeling dizzy. So the less you're doing your homework, the less potential you have for a quicker recovery.
I think we've perhaps answered this already, but are there any vitamins that are good for your ears? I guess the answer is no.
Well, there are certain vitamins on the market right now, so especially people with tinnitus, ringing sound, people say, lipoflavonoids, which is a concoction of different vitamins, vitamin A, vitamin E. So those, they market that they help with tinnitus, but studies really have not proven that. But in reality, really, there's no vitamins that really helps with inner ear function.
We mentioned seasickness and car sickness. What causes them?
Right. So especially people with sickness, a lot of times your balanced organs, they're sometimes prone to a lot of motion sickness. So whenever there's a lot of motion, your body does not adjust to that movement. So your balanced organ, sometimes it does not really compensate the way it's supposed to. So some people, they tend to be more sick than others. But it's the basis. Basically, it's the movement that kind of affects the actual balanced organs, and we also talked about those otoconia as well. So those senses all those movement as well. So sometimes it's some of the dysfunction of the sensory information that can cause more pronounced motion sickness than other people. So.
Yeah, I agree with that. One interesting thing that may have happened to you guys in the audience is you're sitting in your car and it's parked, and the car behind you or next to you reverses, and for that moment you might feel like you're moving forward and you might panic. That would be an example of when your three sensory systems, the eyes, the inner ear, and the body, they're not saying the same message, right? So you can have an inner dysfunction, and if it's a little bit sensitive, like the inner ear itself is sensitive, that could be one cause. But a second potential might be that you have a sensory mismatch. So if you're reading and you're looking down and your vision is telling your brain that you're stable and not moving, but you're actually in a car driving and the inner ear is sensing that motion, that mismatch, it's like when three people are telling you three different messages or two different messages, you could potentially get dizzy from that as well.
Is it possible for an inner ear problem to migrate from one ear to the other?
I would say yes and no. So let's say if the problem is from some kind of infection, and yes, you can have an infection that affects one ear and then you can spread to the other side. But usually, there are separate processes. So like I said, Meniere's disease, it usually affects one ear, but it can be in both ears. But it's not because one ear, it spread to the other side. It's just that there are two separate processes going on simultaneously. So I would say only the infection causes, they can actually spread to the opposite side.
This sort of a multi-part question here. Do you have any idea why vertigo affects women more than men? Could vertigo perhaps be triggered by menopause? And once a person has had vertigo, does that make them more susceptible in the future?
Well, I've looked at studies where they think that the basis for that statement is actually some kind of hormonal dysregulation. So in women, of course, there's more estrogen, so they feel that maybe that could play a role in this. But it's not entirely clear why women tend to have more vertigo versus men.
Here's someone who had the VOR ×2 test today and saw 2 thumbs. What does that mean?
So they probably have a inner ear dysfunction and should see a vestibular therapist for a further evaluation.
I will say that that person, if you're out there, slow down. So move your head. I've told patients to move their head as slow as they can tolerate and as long as the target is clear. So for me, it might look something like this, but if I go any faster, it's jumping. You need to slow down and work your way up. If you stay consistent with it, hopefully the idea would be that over time you can move your head a little bit faster, and the biggest mistake we see people do is this. And that swinging of your head will hurt your neck. That's not the goal of this exercise. Like he said, it's like you're shaking your head no. So it's really small motions. Don't feel like you have to crank your head side to side. The goal would be that you move with more speed. Okay?
If someone is born deaf, does that presage balance problems?
So, it depends. So sometimes, you can have a congenital malformation of the inner ear bone. So depending on the type of the disease, it can affect only the balance part, or it can affect both balance and hearing portions. So it all depends on what type of malformation you have. So I think what's going to help is usually actually we get a CT scan of the inner ear bone to look at all the anatomy, to what's there and what's not there, and then we go from there. So.
Where do you buy grab bars and similar paraphernalia?
I actually do not know the answer to that, but I would recommend starting at a medical supply store. Does anyone else, does someone know in the audience?
There's a medical supply store in old downtown Torrance, not far from the Torrance Bakery.
And someone says you can get them at Home Depot. And Amazon, where you can get anything.
And I know that there's companies out there that can install it so it's really safe and solidified. I think some of those CVS ones might be like a suction cup, so you'd want to be really careful before you just go and trust something that could potentially just lose its suction and fall right off. Is that what you're going to say?
They have to be very carefully installed.
Yes.
People who know what they're doing.
Yes.
So that it doesn't come out. When,
Right.
you pull on it.
So the answer was they should be carefully installed in case it could come out. Suction does work from an anecdotal up here.
But if you're going to grab onto it, it better be pretty solid.
If you go back to that store in Old Town Torrance, they've got all the answers. They've got people that work with them. You may pay a little bit more, but you'll see it, and you get the kind of help you want right then and there.
We have here someone who notices veers slightly when walking and sometimes brushes against a door frame. What is going on?
So that problem, we talked about ataxia or improper coordination. So that tells me, it could be a problem besides the inner ears. You can have a problem in the cerebellum, and there could be, sometimes a tumor or some kind of, a stroke that involves the cerebellum. And so those can cause problems like veering towards one side versus the other. So I think if that's the case, then I would recommend having the patient see like a neurologist actually.
Is there a correlation between vertigo and spinal stenosis?
So there is some correlation because, like we talked about, in order to maintain a balance, you have to have all these inputs from different parts of the body. And when you have a spinal stenosis, some of the sensory nerves can be impinged and affected, so you don't have all the information to actually maintain good balance. But otherwise, the spinal stenosis itself, it doesn't cause that sensation of vertigo, but it may cause an imbalance or unstable gait. So.
There is a condition that we do see called cervicogenic dizziness, where there's a mismatch between the joint receptors in the cervical spine due to inflexibility or impaired joint mobility that can cause some dizziness, but I haven't heard of anyone refer to it as more of a spinning or vertiginous sensation.
If someone has hearing loss in both ears, but it's minor in one ear and major in the other. Would that impact dizziness and vertigo?
So, when somebody has asymmetric hearing loss, we think about any possible causes. So it could be from, noise exposure, and sometimes it could be congenital, it could be a tumor. But usually, hearing and balance organs are separate for the most part. But of course, if there's any tumor that involves, both hearing and balance nerves, then you can have hearing loss on top of vertigo. So it all depends on what's affected. So in those cases, an MRI brain will give us more information.
When I'm standing, I feel like I'm going to fall forward. I'm not spinning, but I feel dizzy. How can I prevent this?
I guess the question I would have is it when you go to stand up?
It says when I am standing, not going to stand up, but just simply standing.
So I would probably call that like a disequilibrium sensation. Is that what you guys would think? Yeah, I feel like there's a little bit missing. I would say from a bottom line safety is if you're this person, I would consider using an assistive device to start, and then we would have to know a little bit more. Do you agree?
Yeah, absolutely. And also, we talked about this entity called orthostatic hypotension. So that's where there's a severe drop in blood pressure when you get up. So, I tell patients to use slow movement when they get up. Otherwise, maintain good hydration and make sure they're on the right medication regimen, because sometimes blood pressure medications can cause those symptoms, especially in elderly populations. So I'd go ahead and review all the medications they're on and look at their health history and go from there. So,
speaking of blood pressure medications, a personal story here. When I went on blood pressure medications, it took about 4 or 5 tries before I found one that didn't make me dizzy. So there's lots of different blood pressure medications out there, and maybe you can find one that works even if your present one doesn't work. We have a question about what do you think of the following home remedy? Lie on your back on the side of the bed and let your leg down and let it hang outside the side of the bed. Does that help with vertigo? Could it conceivably do that?
I have heard of that before. I don't know where that stems from. But the vertigo, the crystal issue is a mechanical issue. So again, that crystal needs to be maneuvered back to that gel membrane. And from hanging your leg off of the side, I don't see how that would be able to help with the actual crystal issue. But it may be if your foot is touching the floor, it can give you some of that proprioceptive feedback to reduce some of that dizziness that you might be feeling.
When you recommend exercise, is stretching without movement considered exercise?
So stretching can, inflexible muscles can actually reduce your balance. So we want our muscles to be as flexible as possible so that they can function up to par. So I would say that having proper flexibility plays a big role in maintaining good balance.
And I would say, just to go off of that, I completely agree with Tim. As far as stretching goes, if you're moving and you're kind of in some type of mindful meditation like a yoga and you're stretching and continuously moving through positions, that might be a good idea because you're going to be working on your inner ear. But the reality is if you can do something like walk, that would be good. If you walk safely with your device or with a family member, I mean, movement truly is the biggest thing that will help. And if it's controlled in a safe way, just keep moving, even if that is stretching without moving yourself. But maybe try adding walking, 5 minutes a day.
Here we have a question about a possible remedy. Turn your head in one direction and turn your eyes in the opposite direction. Hold for 30 seconds. Is that of any benefit? What benefit does that have? Perhaps I should phrase it that way. All
right, that sounds, well, I might be wrong, but from my understanding, that sounds a little bit like this. So your head turns in one direction and your eyes have to move in the equal and opposite way to maintain your eyes on the target. So you don't necessarily have to hold. Maybe what it's referring to is a quick, which would then go back to the same exercise that we were showing. So it sounds a little bit like that type of exercise. I don't know if you have more.
Can a
But
herniated...
it doesn't sound like
excuse me.
they're sorry. It doesn't sound like they might not be fixating on an object. So in order for the VOR to work, you need to have your eyes fixated on a stationary object as your head moves. So if you're just turning your head and your eyes are just kind of going the opposite way, not really focusing on anything, you're not particularly challenging that vestibular ocular reflex or the VOR.
We have a multi-part question here. Can herniated discs in the neck cause dizziness? And when sleeping on my side, I hear a swooshing. What does that mean?
So the herniated disc, it can definitely cause some dizziness, especially if there's any vessel involvement and there's a vessel actually runs along your spine. It's called vertebral artery, and sometimes it can get compressed. Otherwise, just like we mentioned, with spinal stenosis, any kind of compression, blockage in the spinal column, it can cause some defect in sensory perception, so it can lead to imbalance again. And what was the second part of the question, by the way?
Sleeping on your side and hearing a swooshing noise, like the blood is flowing.
Yeah, so that's, we call that phenomenon a pulsatile tinnitus. So you kind of hear your own pulsation, your own blood flow. And that can be from different causes. A lot of times, it can be from some kind of turbulence in the carotid artery. So, people with severe blockage in their carotid artery, it can cause, those kind of turbulence when they lie on one side versus the other. And otherwise, you can also have some kind of vessel abnormality within the middle ear, so that can present like your own heartbeat sometimes. So, that's usually some kind of vessel problem, either in your neck or in the middle ear. So, I'll definitely get it checked out.
Is there a time frame for recovering from vestibular neuritis, and is there any way to prevent a recurrence?
Right. So I tell patients usually, by 8 weeks they tend to do much better. And I mentioned in my lecture that I do give steroids to kind of speed up the recovery process. So usually patient make a lot of improvement after a third or fourth week. And in terms of if you have one episode of vestibular neuritis, if that's going to make it more prone to getting another one, and it is. It's been shown in some cases because, when you have vestibular neuritis, you already have a weakness to begin with, so you may be more prone to get more dizziness down the road in the future. But like I said, a lot of times it's from a viral infection, so you cannot predict really when you're going to get the infection. So I don't think you'll have additional episodes of vestibular neuritis per se, but you may get more dizziness in the future because of the previous vestibular neuritis.
Here's someone who had bad vertigo a few years ago, so bad the person was throwing up, but then it disappeared. Why did it stop? Will it come back?
Right, so that actually description kind of fits along with vestibular neuritis. So again, like I said, it's usually a self-limited condition, but like I said, it can last sometimes weeks. But again, going back to the same question, just because you had one, that doesn't mean you'll get another neuritis. But again, since you already had the episode before, you can be more dizzy in the future because of that.
Another multi-part question. How can excess inner ear fluid be extracted? I guess that's I'll let you answer, but I'm guessing it's with a needle. What are the alternatives to medication? And what causes these crystals to dislodge into the canals to begin with?
Right, so in Meniere's disease, so I told you it happens because of this excessive fluid buildup. So, there is a surgery to decompress it. So it's called endolymphatic sac decompression. It's the source of all this inner ear fluid. So it's actually a brain surgery, so they have to actually open your skull to get to the sac. So it's a big surgery. And it's only done as a last resort a lot of times, but otherwise, we don't like to do surgery in these cases, so we try like water pills to try to secrete all those extra salts, so you can actually decompress the sac a little bit. But usually surgery is not the first line option.
Here's someone who had meningitis as an infant, is now a senior. Will this affect me now? The meningitis was completely cured before the person reached 1 year old.
Right, so as long as the patient's completely cured and there's no hearing loss currently, I don't think it's going to have any long-term effects. Of course, I would recommend that patient get a formal hearing evaluation just to make sure that patient can hear okay. But as long as somebody recovers completely, then usually it's okay. So,
does a hearing aid help in the case of someone with tinnitus?
So it can, or it can do more harm actually. So it can help in the sense that you can mask some of the tinnitus sounds because hearing aids, they amplify all this background noise. But at the same time, it can also I've heard people saying it can actually make the tinnitus more pronounced. So it can be kind of a double-edged sword in a sense.
What should one do when confronted with instant vertigo? I guess that means coming on suddenly.
Right. So usually if you're in the middle of something, let's say if you're driving, of course I recommend that you just pull over to the side and just stop driving. But usually I tell patients to just stay down, try not to move too much, and then once the initial vertigo episode improves, then we talk about taking medications, and I talked about meclizine, all those kind of anti-vertigo medications, and those are usually only temporizing. But if patients they do need it, then I think it's not a bad idea to take them. But eventually, what's going to happen is that those patients will go to emergency or sometimes come to ENT clinics, so we do a full evaluation that way.
When you're having an MRI to look at inner ear issues, is contrast necessary? And then there's the word tumor in parentheses.
Yes, so I know that contrast is always a concern for a lot of patients. It does help because with contrast, you just see more details, especially when there's a concern about a tumor. So I usually get MRI with contrast if possible. But of course, with MRI scans, and there's always, you can still get a lot of information without the contrast. But if I have a choice, yes, I do recommend getting an IV contrast.
Here is someone who has a PPO. Can I go directly to a physical therapist for evaluation if I suspect an ear canal problem?
So it's a little different with the hospital setting. We do need a script from a physician, whether you're a PPO or an HMO. But physical therapists have direct access in all 50 states, meaning that if you were to go to a private practice physical therapy clinic, you could see a physical therapist directly without seeing a physician first. And each state has a little bit different rules on how long you can see that therapist before following up with a physician. But to answer that question, in all 50 states, you are able to see a physical therapist first before seeing a physician. It's just a little bit different under the hospital setting, where you would need a script first.
Now, a request for your thoughts on medical marijuana for migraine relief and for core strengthening for balance.
Well, I don't have a lot of personal experiences per se, so I can't really comment on that. But I would say whatever helps you, continue doing it. That there's no harm. So, yeah, because vertigo is a very challenging problem. So I think anything that can help, as long as it's within a legal boundary, of course, I don't think there's any problem. But there has not been any studies looking at that, so I cannot really say, cannabis is effective for this. So, but if it helps, then it's an option.
Okay, we have one last question, and I'm not quite sure what it means, but I'll simply read it. How do two gyros stay in phase? Can you figure out what that means? Maybe this is something best reserved for after we adjourn here. Come up and ask, and maybe you can clarify the question there. So with that, let's thank our panel for a very interesting discussion. And don't forget, next month is the second Wednesday, not the third Wednesday. So come on the second Wednesday of the month in November. Thank
Wait,
you
I
and
might
good
have an
night.
answer.
Oh,
I'm assuming that the gyros are referring to a gyroscope, if I'm correct. Yes. So, right. Right. So it's like a push-pull mechanism. When you turn your head left, the left will be activated and the right on that plane will be inhibited. It's pretty interesting. They work in, what's the word? They work together. So when you look up, both are going into in phase. Yeah, they're working together.